So good morning. As JP said, my name is Cristal Brown, and I'm a clinician scientist, and my research interest is focused on serious illness communication and shared decision making. I feel very passionately that if we empower both patients and providers to have better and more effective shared decision making, that we can improve the quality of life for patients. And so I was really excited when I had the opportunity to talk about this today in hepatitis B.
Thanks, Cristal. Good morning, everybody. I'm Robert Gish. I'm actually based here in San Diego, and my hepatitis B practice is very diverse. I work in a federal clinic here in San Diego called La Maestra, and it's the most diverse zip code in the United States. We have 42 languages, so I'm working with patients with hepatitis B daily in many different languages. It could be Nuer from Sudan or Creole from Haiti, Vietnamese from Vietnam, obviously. We have a lot of patients here from Burma. I use the Burma name, not Myanmar, for political reasons. And those patients can speak Karen, Burmese, and there's a couple other regional languages. So we really have to be language sensitive and culturally sensitive. So I'm constantly getting training, like what's going on. Sometimes the interpreters actually help me. There's people in that clinic. I work in a rural clinic near Sacramento, a GI group also near Sacramento, Santa Rosa, multi-specialty group. I have a telemedicine group, and I'm building a liver clinic in Las Vegas right now. So very, very diverse environment for hepatitis B. I work with the Hepatitis B Foundation, and I was really, really happy with the new AASLD guidelines, which we'll talk about later, that they brought shared decision making into our environment in a very frontline position and made the patient the center of the discussion instead of the physician, the provider that's part of the team, but the patient should be at the center. So we're going to get into that in just a moment. There are some disclaimers here that we have. It's super important, and we're going to be talking here about disease state, and there's going to be some scientific discussions that are here. This is not promotional. There's no product information that you're going to hear at this meeting. We really want to elevate awareness and elevate how you have dialogue with your patient today, and Cristal's really going to be focusing on that. I'll get a little bit of data here at the beginning, or tables to talk about. The subject matter, of course, is the epidemiology of hepatitis B and how you can use that in your conversation. I think that is super important. This, of course, is supported by GSK, and they're committed to making this a quality event for you, including making your conversations safe and, of course, safety of their products that are in development. Okay, disclosures. I have to say there is a little imbalance on here, Cristal. I'm sorry about that. I work with everybody, so it gives me a little bit of perspective on this world, but super involved with hepatitis B. We're not going to really talk about Delta hepatitis today, but that's part of the picture. Although there is Delta on one slide, just to remind us that every hepatitis B patient should be checked for Delta. So we'll keep that in mind also. So we're going to be talking about this shared decision making, but we're going to talk about what the new framework is with the AASLD IDSA practice guidelines. I'm going to make a few editorial comments about that because I've got a little bit of a bias towards the Chinese guidelines. I'll talk about that in just a moment. And this communication tools that we have. I use motivational interviewing in my patient discussions every day. It's a little bit less important with hepatitis B, but motivational interviewing is also quite useful in keeping adherence and compliance at I think, a top position. So yes, we can all be better communicators. And when I'm talking to my patients, I used a tool I learned recently called the pause. So I ask a question, and then I just don't say anything for 3 to 5 seconds and allow the patient to really think about it. We have a habit of talking over patients, talking over our colleagues, interrupting people. It's really important to ask a question and then wait for that patient, give that patient time to fill in their answer. And they will. If you pause and don't say anything for a while, the patients in general will come right back and feel that time that they can communicate. So my first comment on this EPI slide is that we use the number at the Hepatitis B Foundation up to 2.4 million. That was a paper that Robert Wong and I published. Homi Razavi had a recent paper that's in the 1.8 to 1.9 million range. but often we underestimate disease, and that's just because of under surveillance tools that are here. But this is a very diverse disease. 70% of the people are first or second generation, mostly first generation immigrants. And we have something here that's unknown, probably because there's a lack of data granularity. But this is definitely our diverse population that we have in the United States. So the Asian population is super important, as that's where the bulk of hepatitis B is in this world. And there's a whole issue too. We'll get into vaccine in a little bit. This isn't a vaccine meeting, but vaccine is a key part of managing hepatitis B. Now, it's really interesting that when you talk to patients about the natural history of this disease, we've always focused on cirrhosis, cancer, transplant, and death. But the conversation is much bigger than that. And that conversation is about stigma, discrimination, quality of life, extrahepatic disease, other types of cancer, infectivity. So we'll get into that because that really wraps around this concept of treating just about everybody with hepatitis B, although the guidelines still put viral load somewhat in a top position. The number of deaths that are here and impacts are huge. And I just basically make it simple. 2 people die every minute from hepatitis B somewhere in the world. When I use that byline at different organizational meetings, it really gets people attention. It's a number they can really, as I say, sink their teeth into. Now, liver cancer, even though it's the 3rd most common cause of cancer mortality, it's the most fatal form of cancer. There's a lot of other cancers. We have, other treatments. So lung cancer, resection, liver cancer isn't just liver cancer. It's in the background of liver disease and cirrhosis in most patients. This is just a huge, huge problem. I just spent 2 weeks in Africa this last year, and there's all these, 20 and 30-year-olds dying of cancer. And it's just very, very, very sad. All right, let's get into impacts. So we're talking about individual impacts, of course, and there we'll be talking about with Cristal a little bit more about fear and the impact individually of patients' care. There's financial loss, of course. There's issue of finances of getting access to medications, and I deal with that. Although it's interesting, in the federal clinic system, I have access to all the hepatitis B medications very easily. There's other insurance challenges for people with copays, et cetera, that are out there for people. And this whole issue about being an infectious disease, I think that's underemphasized in the different guidelines, and it should be one of the top issues. It's not just being infectious, it's the fear of being infectious. So this issue about stigma, self-stigma, self-isolation, social isolation is something that I've learned from my patients as well as some of the surveys that have been out here. The stigma is a very interesting subject. We published at least 2 or 3 papers on that about 5 years ago, about the impact of hepatitis B on individuals' life. And I'd never had thought about stigma before we did this large project, and it's now in my brain and it's in the peer-reviewed publication. So I think this is very, very useful. These individuals may get married later. There's this whole issue about having hepatitis B and telling a partner and they need to be tested, need to be vaccinated. Makes relationship development, I think, much more complicated. There's a number of societies where you have hepatitis B, you are ostracized from that local community. And it's just very, very sad for personal development, career development. In the Philippines, you have hepatitis B, you're not going to work for any large corporation. You're out. You're going to be, okay, you can run a restaurant, you can have your own individual business, but you're not going to work. And one of the biggest exports from the Philippines is people. They have great English skills, they in nursing and home care and other things. And you get tested, you're there, you're out of that global impact that the Philippines have on us regionally. So this is a little bit important too about lived experiences. And these are quotes from patient interviews. I think this is from Catherine Freeland's manuscript. I work with Catherine at the Hepatitis B Foundation. And there's issues about worry, concern, fear, impact, and again, back to stigma. There's this whole issue of psychological well-being. And this is really a chance for you in clinic to have that listen, that dialogue with that listen with your patients. And I think it really makes an impact when you start therapy. Now, the last 100 patients that I've recommended therapy to, I've only had 2 patients decline treatment. And these are 2 older male patients who just are absolutely fixated that they don't want to take a pill every day. I talk about all these other impacts. Does it impact them? They're worried about the pill. But 98%, I say treatment. Treatment gets initiated. The compliance rate is super high. A little bit more on the AASLD IDSA guidelines. As you recall, they had only 6 questions. They didn't answer all the potential questions, and this was limited because of rules about the guidelines and the finances of answering different questions. And they fell back on this 2,000, 20,000 threshold, unfortunately. I still think that this is a problem. If you put that number up and you hang on that number, the insurance companies can often block access to drugs. But deep in this document is the shared decision-making, bringing the patient back to center. There was over a year delay in getting these out because the first pass was just about numbers, and the second pass was about the patient. So AASLD is growing up, I have to say. I'm really, really happy about that. But it took some time. WHO guidelines, which came out 2 years ago, were also delayed a year because of the work of Sue Wong and Hepatitis B Foundation, Carla Thornton, Saeed Hamid, really putting pressure on WHO to bring the patient back into the conversation. And WHO guidelines give you a lot more flexibility, especially because they're covering the whole world, not just a first world country with lots of resources. And of course, the China guidelines is if you're over 30 and you're DNA positive, treat. This is the biggest country with the biggest hepatitis B population, and they've decided to treat everybody. There's a lot of logic behind that. So I think that's the guideline that helps guide me. We do have a project going with CLDF about a guideline to the guidelines, and we will encourage you this next year to take a look at that document. So the guidelines help us. Remember that, they're just guidelines. If you dig deep into that, they do talk about infectivity. They do talk about other impacts. So AASLD, as I said, is growing up, which is super good. And now we're going to dig into the next layer. Cristal.
Thank you. So we're going to shift gears a little bit to talk about shared decision-making and patient communication in chronic hepatitis B. And so when we think about shared decision-making, what does that mean? And it means that the patient and the provider are working together to make medical decisions that are really based on the patient's values. So we're putting the patient at the center of the conversation. When we do that, we increase our ability for patients to have disease understanding, to be able to build trust between the patients and the providers. We may also include family and social support when we kind of open those doors to allow family and other caregivers into the conversation. That can be very helpful for the patient. We also want to improve and focus on quality of life. We want to support treatment adherence, and then ultimately to have more positive outcomes. And so that is why shared decision-making really matters. And so we're going to talk about 2 frameworks, and we're going to start with the SHARE approach. And so this acronym begins with S, and S is to seek the patient's participation. So we want to create an environment in which patients feel comfortable and safe having these conversations and being a participant in shared decision-making. Then this is the part that we're probably the most comfortable with, helping patients to explore and understand their treatment options. So this is the medical information that we give them. What's very important, though, is that we're not using a lot of medical jargon and talking over patients' heads. If we don't give them information in a way that they can really understand, then they can't make an informed decision. And so while we're helping them, we need to make sure that the patients understand. Then we want to take the time to assess their values, their preferences, their situations. And sometimes patients open up and they're very honest about, I can't afford my medications. I have other competing issues. There's something else going on about my values or preferences. But if they don't offer that, we want to create an environment that encourages it. And then we reach a decision, right? We take all of that information, what our options are. We want to take the patient's preferences, put all of that together to reach a decision. And then finally, we're not stuck with that decision, right? We're able to evaluate it and come back and say, if that maybe isn't the right decision as things change, should we change course? And so let's take a clinical vignette here and actually go through this shared approach. So in this case, it's a 42-year-old patient who has surface antigen positive and e antigen negative chronic hepatitis B that falls into an indeterminate phase. and they're unsure whether to begin antiviral therapy, and their concerns are specifically around pill burden, cost, and long-term monitoring. So here, when we seek to have the patient participate, we want to tell the patient, hi there, I have reviewed your labs. I see that you are in a place where we have more than one option for how to treat your hepatitis B. And then I think the most important part of that is to ask them to say, can we talk about this a little bit more? The importance of asking is that if for some reason the patient isn't in a space that they want to talk about this today, you give them the opportunity and the autonomy to say no. And maybe that's because they want to have their partner there, or they need a different situation to have a really empowered conversation. So I think one of the key points here in this participation is just making sure that the patient is ready and forecasting that conversation. Then we're going to give them the information that they need to make this decision. So what does it look like if we observe, and what would be the frequency of our monitoring? First is if we start antiviral therapy, what would be the options if we're going to start medications, and what would it look like from a monitoring standpoint? And then this is where we can dig deep to understand a little bit more about these concerns of the pill burden, the cost, the monitoring. Why are these issues for the patients, and how may they look different if we choose one path versus the other? And so for this patient, because we've said they're really concerned about pill burden, they're concerned about cost, then maybe we decide that observation is going to be what we do. And we go and say, okay, 3 months, 6 months, we're going to come back. We're going to do another set of labs and see where we are. When we evaluate, it means we may not decide to stay there. Once the patient has a chance to go back, process this information, maybe do some independent research, because our patients have all access to the internet and looking things up, but also talking to their family members, then they could say, you know, I actually had time to consider antiviral therapy, and maybe that's the path that I would rather have. So this is the way that things could look if we went down a shared decision-making path with our SHARE approach. But then another framework is the REMAP framework. And this is a framework that allows us to discuss goals of care and to align patient values. And so with this acronym, R is to reframe, E is to expect emotion, M is going to map out patient values. We're going to align with those values and then propose a plan. And so I'm not going to spend too much time talking about M, A, and P, because those are very similar to what we talked about in the SHARE approach. I do want to spend just a minute or two talking about the reframing and the expecting emotion, because these can be challenging parts of the conversation. When we think about reframing, particularly if we come in and we're having this new diagnosis, that can be an overwhelming feeling for a patient. And they may come into the conversation and just feel so overwhelmed, they're not sure where to go. When we reframe, we say, hi there, I know that I'm giving you this new diagnosis that may feel overwhelming, but this is a chronic disease that can be managed. Is it okay for us to talk a little bit more about how we can make decisions to be able to manage this in a way that aligns with your values? It's just framing that conversation in a way that the patient can actually absorb the information. But we're also going to be expecting that emotion. And not only are we talking about hepatitis B, but we know that there are very serious complications. We could have decompensations, we could develop liver cancers. There's very serious information that we're giving patients. And if any of us have ever gotten bad news before, if someone continues to just talk after they give you that bad news, you hear nothing else except that really serious thing that they said. You know, one of the best examples, I think, is, you know, you have cancer. Everything else that's said after that is lost, unless we take the time to expect that emotion and let people process. And so, as Dr. Gish said, a pause can be so effective. To just be silent, to give people a chance to really process what is happening, and then to actually acknowledge it and understand why are they having this and feeling. And so expecting the emotion is really important before we move into the meat of talking about options and making decisions. And so when we do these things well and we have this shared decision-making model, we want to actually have effective communication. And so that means, as I've said, avoiding medical jargon. If patients can't understand what the medical information you're presenting, then they can't make an informed decision. We also want to practice active listening, right? We're not just here to talk. We want to actually listen and absorb what the patients are telling us so that we can help advise them and walk them through this decision making. I think we should just acknowledge that managing chronic hepatitis B is hard. I think of all the things that I manage, I find chronic hepatitis B to be one of the most challenging because of all of the different phases and being able not only to have conversations with colleagues, but conversations on a patient level can be really challenging. And then we want to invite family and social support into this. Some of these people, this is a transmitted disease, so they may have stakes because they're an intimate partner or they're in the household, but it just may be that the patient needs someone to help support their decision making. And so being open and inviting those people into the conversation is extremely important. And then just the pause, as we've said, to really let patients participate and to not just take over these conversations. And back to Dr. Gish's point about cultural competency, hepatitis B affects so many different people, and we have to be cognizant of the cultural issues that can be barriers to effective communication. So always using a medical interpreter. These are very nuanced conversations, and so things can get lost if we're not actually allowing a medical interpreter to ensure that the patient understands the information. We want to respect their beliefs and values. And so I would say one place where this has come up for me is that in some cultures, the patient is not the person that is making the decisions, but there are family members that are there that are gathering the information and making the decision. That's, I believe very strongly in patient autonomy. And so for me, when I first started, that was a little bit jarring. And I felt like the patient should be the one making the decision. But I had to respect the fact that if that's the way the patient wanted it, that's what we should do. And so understanding those differences in beliefs and cultures is really important. And then lastly, just understanding our own biases in our own culture, that we're going to bring some of our own things into these conversations, but not to let those distract us. And then one way to make sure that we've actually done a really good job and had an effective conversation is the teach back method. So once we've talked to people and given them this information, have them repeat it back to us and ensure that they understand what we're talking about. This gives us an opportunity that if what they tell us back is not what we have said to them, we can try to say it in a different way to ensure that they've actually captured the understanding of the key concepts that we have. And so with this information, we're going to transition over to our case and have a conversation about how to use shared decision making. So in this case, the patient is Nam. He's a 24-year-old male who was born in Vietnam and immigrated to the United States when he was 2 years old. He's referred to the GI and hepatology clinic for a positive surface antigen test. So he's had some confirmatory tests 6 months after his first positive result. And so he once again is surface antigen positive. He does also have core total positivity, but the core IgM is negative. His E antigen is positive and the E antibody is negative. We have a DNA viral load of 20 million and the ALT is 20. So Dr. Gish, I'm going to ask you, how would you communicate this diagnosis and talk about the lab results specifically to the patient?
Well, Cristal, you made a very important point about how complex hepatitis B is, but I'm actually going to take the opposite position. This is very simple. Person's got a virus, they're DNA positive, they need to be on treatment. And then I move through very quickly these other laboratory changes by saying, you have this virus, high risk for cancer and cirrhosis. Let's make it simple. Can you make it simple for your patients? It's much easier to get them on treatment than digging a deep dive into E antigen and this term called immune tolerant, which is still in the AASLD guidelines, which is a completely out of date term. So there's these phases that the European EASL uses, which is chronic infection or chronic disease. But even that makes it a little bit too complicated also. DNA positive treat. Of course, we're going to stage their disease because that's going to impact on how we do surveillance strategies. The E antigen is, I think, very old school. This is in the US, it's less than 20% of our patients are E positive. If you go to different parts of Asia, it's sometimes only 10% are E antigen positive. There's a younger population, an earlier phase of the disease, wild type virus. We don't do core and pre-core mutations anymore. We don't do genotyping anymore. E antigen helps a little bit. But I think quantitative surface antigen is what's missing from this slide. I do quantitative S antigen on all of my patients annually. I find it very, very useful. There's a great paper that just came out this week on liver cancer risk. It's not the first one, but higher S antigen, much higher much higher risk of liver cancer. It's higher risk of infectivity, lower chance of natural clearance. So quantitative surface antigen is one that I do spend time with my patients on. There's other research tools that are coming forward, HBV RNA and correlated antigen. Those aren't ready for prime time in clinic yet. And ALT is a liver enzyme. We've really getting rid of that word LFTs. That's out of date. Don't use LFTs in your practice or talking to colleagues. These are liver enzymes. But this is one point in time. Elastography is going to give you a lot more information about stage, using Fib4, spleen size, portal vein diameter. But I do try to bring it back to this very simple approach. DNA positive, treat. I think that's a simple way. Do you agree?
I agree. I think totally. I would say from my practice, I don't use the surface antigen quantitative very much. And as we have worked on this, I think that's going to be a difference in my practice.
Excellent. All right. He responded to the diagnosis with disbelief, anxiety, and fear. How are you going to allay these fears?
Absolutely, right. We're going to get back to our remap with this. And I think we're actually going to change the order a little bit. Instead of starting with the reframing, we have this emotion that's in front of us, right? The patient is saying he's in disbelief and he's afraid. And so I think to stop and just acknowledge and say, I've given you this diagnosis of chronic hepatitis B, and you seem really shocked and really scared about it. Can you tell me a little bit more about why you're so afraid? Why are you so shocked about it? Where we have our opportunity for reframe is that he's saying, I live this clean health style. This gets to the stigma, right? He's already saying and internalizing that because I have this diagnosis, it means something bad about myself. And we want to reframe that and change that. And we want to say, having this diagnosis does not mean that you've made lifestyle choices that were bad choices. It just means that you contracted this disease and we need to manage it. I also think another point in here is that he says he feels fine. And this is an opportunity for us to educate the patient and say many people are asymptomatic, but that doesn't mean that you don't need to monitor and that you don't need treatment. And so these are opportunities for us to really to dig into this emotion, but to also reframe and move forward in our conversation.
That's great.
And so now the patient wants to know, can hepatitis B be treated with medication and can it ultimately be cured? And how are you going to talk to them about that, Dr. Gish?
Well, we came up with at the Hepatitis B Foundation in 2013 with this word functional cure, which is an oxymoron like Civil War or plastic glasses, because it's really not cured. But by going into a little bit of detail here, clearing surface antigen, DNA negative, and those are the two tests that I focus on, we can then get to a state where your chance of cancer is reduced 70 to 90%. Your chance of needing a transplant, as long as you don't have fatty liver or alcohol, is reduced maybe 99%. The patients are super happy with taking one pill once a day. Then, of course, we have to come back to the fact this is chronic therapy. I never use the word lifelong. That's very depressing to a patient to hear lifelong. So I use long-term, and then I tell them there's 50 or 60 new medications in development. There is hope that we're going to get not just a functional cure, but maybe complete cure or sterilizing cure in the next 10 to 15 years. So you're going to be on this for a while. New therapies are coming. Give them hope. Keep it positive. And that's where motivational interviewing has really helped me a lot. How to turn a negative into a positive and really closing out the discussion with these positive messages. I do want to go back to what you said 2 slides ago about getting that patient engaged. I start out my discussions with every patient in every clinic every day by asking them, of course, how are you feeling? Is there anything new with your medical care? And my third question is, what's your diagnosis and what's your stage of your disease? Tell me what you remember from your other provider. Tell me what you remember from our last appointment. And some patients are just completely blank. They don't remember anything from the previous appointment. Or they say, I have hepatitis B, but I don't know the stage. Please help me. So we get into that a little bit more detail, but you can set the frame by asking the patient, where are they that day? What do they understand about their disease? And then you build back on that. All right, patient is anxious, back to simplicity, be on treatment, improve quality of life. I do want to put one more quality of life issue. When patients have virus that's suppressed on treatment, or maybe some come off treatment, we'll talk about that, they actually feel better. They feel better because they're on treatment. They feel better because they're suppressing an inflammatory disease. But there is one catch about stigma. Jordan Feld taught me that people who take hepatitis B medications, some, are actually stigmatized because they're taking a medicine every day. And this is where this future of finite therapy is going to come into play as these new therapies come out. Give the patient hope, better life, longer life, but also the chance to come off treatment someday. That's nice.
Absolutely. And I think one of the highlights of the guideline is really around the shared decision making of taking into account these things. So their age and their sex, their stage of disease, family history. So getting into pill burden, all of these things that help us to make a decision that is concordant with the patient's values. So although it may be that we are trying to treat everyone, we also want to make sure that they understand and know that this is aligned with what they want because we're addressing whatever issue is important to them. And so these are some of the things that we can specifically look at.
That's great.
And so now the patient has started their nucleotide analog and they're adherent to treatment and they're monitoring and they've had no side effect or issues and they're taking their medication and doing great. He and his then girlfriend are now married. They live in their own home and they have one son. His wife and son are vaccinated and they have documented protective antibody titers. So now when we do his labs at 3 years of follow-up, we have a HBV DNA that's undetectable, an ALT that's 25, a qualitative surface antigen that is positive, and he has seroconverted his E antigen to antibody 18 months ago.
Where's that quant S when I want it?
I think they were giving you the volley on that one to be able to bring it. So here, the patient is strongly considering stopping antiviral therapy since he feels his life circumstances have changed. And so how are we going to assess whether that's the right thing for this patient to do?
It's back to this quant S story, and the guidelines have put out some really good numbers on the front line that this quantitative S antigen, less than 100, has a chance of stopping therapy and seroconverting S. As you know, if you're on a chronic therapy, the chance of hepatitis B surface antigen seroconversion is less than 1% per year. But stopping therapy in the right band of quant S, it could get up to 20 to 30% chance of clearing S. But stopping therapy does require monitoring. There is a fear of flare of stopping therapy and having a flare of liver disease. It could be life-threatening. But we don't live our life off anecdotes. We live our life off data. The chance of a severe flare with stopping therapy is 2 out of 1,000 people. And that's in prospective studies. A Canadian study led by Harry Janssen was really, our STOP study really looked at this in detail. It's very rare to have a life-threatening flare, but it's still an anxious issue. Monitor your patients when you stop. Be selective off quant S.
Absolutely. And so we've put up here, we've gotten from that, the guideline that when we are thinking about discontinuation, here are some of the things that we want to very specifically look at.
Fantastic.